Healthcare costs in the US are rising, systems are inefficient, and people's health in general is getting worse. Dr. Nash is board certified in internal medicine, and the most recent book, best-selling How COVID Crashed the System.
And an article in the American Journal of Public Health first introduced us to the term population health. Patient engagement is at the very center of what population health is all about. Now there's no excuse for patients to fail to be engaged. Physician leadership training is the number one thing that current leaders must do to prepare future leaders. Harness ChatGPT in undergraduate medical education. Here we are in 2025 after 30 years of work, and medical error is still the fourth leading cause of death in America. Individualism, exceptionalism, and federalism, that's what America is all about. GPT 4.0 is even more powerful, and it's not going to replace us, it's going to enhance our capabilities.
In each episode, we dwell into the realms of wellness, exploring the latest trends, expert advice, and practical tips to help lead you a happy, healthier life. We aim to bring a broader perspective to our American audience on issues that impact your daily life by interviewing guests from the US and around the world. From nutrition and fitness to mental well-being and beyond, we're here to empower you with knowledge and inspiration. So whether you're looking to boost your energy, revamp your diet, or simply trying to find a balance in your lifestyle, you're at the right place. Join us as we embark on a journey towards a better, brighter you. I'm your host, Dr. Amir Khan, and together let's unlock the secrets to living life to its fullest. For decades, the healthcare system has focused on treating illness rather than preventing it. Despite groundbreaking advancements in medicine, patients' outcomes are still far from where they should be. Healthcare costs in the US are rising, systems are inefficient, and people's health in general is getting worse. But what if we can revolutionize the healthcare, not just for individuals, but for entire communities? Imagine a future where data-driven strategies, physician leaderships, and policy reforms work together to create a healthier world for everyone. Join us as we uncover how data, policy, innovation can reshape the future of medicine, improve patient outcomes, and empower physicians to lead the charge in value-based care. Welcome to another Insight episode of KhanKlinics. I'm your host, Dr. Amir Khan, and today we have an extraordinary guest, Dr. David Nash, a pioneer in population health and healthcare quality. Dr. Nash is an American physician, a scholar, a public health expert, and named the chair professor for health policy at the Jefferson College of Population Health in Philadelphia. Dr. Nash is board certified in internal medicine. He's also completed his MBA at the University of Pennsylvania. Honors received by Dr. Nash include honorary doctorate. He's authored more than 100 peer-reviewed articles and edited 25 books, including the quality book Demand Better and the most recent book, best-selling How COVID Crashed the System, a guide to fixing American healthcare. Dr. Nash is currently the editor-in-chief of the American Journal of Medical Quality and Population Health Management as well. Dr. Nash, welcome to the show.
Thanks, Amir. Great to be here.
Well, we got an exciting list of questions for you. Let's start from the basics.
Okay.
And we want you to tell our audience, what do you mean or how would you define population health as it is?
Wow. Okay. So let's go back in history to 2008 on the campus of Thomas Jefferson University in Philadelphia, which has been my home for the past 35 years. But in 2008, the Board of Trustees at Jefferson decided it was time to build a brand new school from scratch. And remember, this is 2 years before Obamacare, which was 2010. And the board and the university president at that time thought, well, this new school should be focused not just on public health, but on issues like health policy, health economics, and healthcare quality and safety. So if we put it all together, that's what population health is all about. So it's public health is at the core, and we're surrounding it with issues like health policy, health economics, and healthcare quality and safety. One analogy we used to make that all of that, that's the roof of the house is population health, and it's held up by the various pillars, with the central pillar still being public health and all of its key tenets. Population health, the term itself, we generally attribute that to Dr. David Kindig, Kindig, still alive and working at the University of Wisconsin in Madison at their Institute for Population Health, who in 2003, that's a long time ago, in an article in the American Journal of Public Health, first introduced us to the term population health. So my summary is it's still a lot of public health, but we're surrounded with all these other critically important issues, especially in America.
Excellent. And thank you for summarizing that. It seems like it's still public health. The patients are at the core, the public is at the core,
Right.
But yet you have made people or the system aware that there is an economical part to it. There is
Right.
economics, there is safety, and there is quality.
You bet.
And that's the umbrella, sort of like that's surrounding. So very, very nicely explained. Thank you for doing that. Let's go into the next question. And that's basically, we want to know and tell us, our audience, you've been a leader in population health for now decades. What inspired you to focus specifically in this field? We want a little bit of insight from Dr. Nash's perspective.
Wow, that's a great question, Amir. So again, let's go back to where I was in 2006 and 7. At that time, I was the chairman of a medical school department of health policy. So Jefferson Medical College, now Sidney Kimmel Medical College, but 2007, Jefferson Medical College was one of the largest private medical schools in America, still is. And I was very privileged to already have achieved tenure, be on an endowed chair in health policy. At that time, there were roughly 120 allopathic med schools in America, and about 24 had a non-clinical department focused broadly on issues like policy, public health, health economics, and so on. And so at that time, I thought, okay, we're doing well. When the board decided to build a new school, I was actually essentially plucked out of the medical school and made the dean, inaugural dean of this new college. So I wish I could say that it was a planned event and that I had decades of thinking about population health, but the truth of the matter is I was a med school department chair, very happy doing the work that chairs do. And it was a great opportunity at the right time. And I happened to be sitting in the right place at the right time when many leaders, who I give them a lot of credit, especially going back to 2008 and 9, said, well, we want to build a school that will in turn create leaders for a new type of system. And I'm very proud of that accomplishment and all the subsequent work that many other people have done, including our new dean, the second dean, Billy Oglesby. But Amir, the inspiration came from a university-wide strategic plan that called for a new school to build new leaders for the future. That's really what my stimulation was to get this job done.
Excellent. So it seems like there was a calling and you opted to stand up and had the insight and wanted to be a part of the future.
That's correct. And I had already been at Jefferson for 18 years. So I knew my way around, and I think the university leadership at that time thought, well, we don't have to do a national search, we'll just make Nash do it. And I was willing, able, and available, the very key attributes at that moment.
And thank you for explaining that. Dr. Nash, you're on a journey now and you've learned a lot of things on the way, and you've obviously contributed to this field tremendously. And you still are very active. Before we go on to discuss the hospital systems and healthcare systems and how we can improve, give us a little bit of an insight about what do you think, in your eyes, is the patient's role in this? Patient engagement in achieving better health outcomes, specifically at a population level or a community level.
So I've always believed, like the leadership at Harvard Medical School, who first coined the term "nothing about me without me," Tom Del Banco and all of his followers. So I've always ascribed to that theory. That's sort of part one. And part two, by providing transparency and public accountability for what we do as clinicians, that's how you engage with the public. So I have led, as an example of this, the work in Pennsylvania as an advisor to be as transparent as we possibly can on the outcomes of care on a DRG by DRG basis for every hospital in our state. We have one of the largest, oldest 30 plus year history data sets that describe in quite some detail, even at the doctor level, how are we doing and how do we compare with other states and with other systems and countries around the world. In any event, patient engagement starts with transparency of our outcomes, and patient engagement also depends on the notion that nothing's going to happen to anybody without their understanding, their permission, and their participation. And today, nothing could be more important than having patients engaged in their own care. Everyone will be a patient, has been a patient, including myself, of course, and I'm always learning, and being a patient is a big job. And I wish we had better tools and better education, but I think patient engagement is at the very center of what population health is all about. Sadly, many organizations, don't get that and don't provide patient education and would like patients to be very subservient and not ask questions, not upset the apple cart, not confuse the system, and all the rest. So very important to have patient engagement.
And then you have, I think, quite nicely explained this, obviously from the physician community or the medical community, I would say, not just physicians. There is a bit of a pushback.
Yes.
And because we are used to having, like you said, the patients being subservient, not asking those questions, not engaging in their management, or kept at bay, you have turned this upside down and want the patients to be taking the key role, not the management.
That's correct.
Not others, but it's a more like a partnership.
Yeah.
And we see that.
It's not a widely held view, Amir, as you're probably well aware. So
I am very aware.
There are a lot of our peers who would prefer that the patients do what they're told, and even more sadly than that, don't offer opportunities for additional education and engagement. And in the era of the democratization of clinical information based on the internet, ChatGPT 4.0 and the like, I mean, now there's no excuse for patients to fail to be engaged. They have to be engaged.
You mentioned that you've been using data as a center point to try to make these changes, starting from the patient's perspective. What are the hindrances have you noticed and come across when you're trying to put these hardcore measures in? And do you feel that these are at times an impediment to the care that the patient would receive? So there's two parts to the question.
Yeah, that's a two-part question. Let's just start with a little bit of history. So going back to the early 1990s, we published what turned out to be a breakthrough piece in JAMA in 1991. That's a long time ago. where we were looking at the differences in mortality from coronary artery bypass graft surgery, open heart surgery in Philadelphia in 5 medical school hospitals. When that paper came out in JAMA back then, for a little bit of context, we were not allowed to name the institutions, Amir. They were hospitals A, B, C, D, and E. Now, as it turned out, Hospital D was Jefferson, who had the best outcomes at that time. But
Wow.
putting that aside, that paper and the paper from colleagues at Dartmouth Medical School and many others was accompanied by what I think is one of the greatest editorials ever written by Don Berwick, who said in that issue of JAMA, August 1991, for experts to admit that they could do a better job, it will make those experts vulnerable. So to answer your first question, the biggest barrier we have is experts admitting that they could do better. I mean, all of our training tells us that we are at the center of the known solar system and we're great. And you're lucky to see one of us. Whereas the truth is far from that, sadly, that we have a normal distribution of doctor attributes, as so eloquently written by people. And in the book Better, he describes in detail all of this. So look, I think understanding that our culture is all about training to be an autonomous expert, whereas the system is far more complicated than that and requires many interactions with other individuals and other technologies. And yet, medical education is still sort of suffused by you're at the center of the known solar system. So we have this real challenge. The second part of your question is even more complicated, which is what's the right measure? Is mortality the right measure for open heart surgery? Well, maybe in 1991 it was, but not in 2025. We need better measures. Sadly, before COVID, I think we found ourselves in a world of, many experts like Bob Wachter and Peter Pronovost have said, in a world of measurement mania. Too many measures, doctors or nurses are overwhelmed. So in the post-pandemic era, I think we need better measures that make more sense to clinicians. And we're working hard to try to figure that out. And measures that take into account issues like race, poverty, access, education, and all the other challenging social determinants of health. So maybe we're at a tipping point where we're going to develop better measures. I hope so. So it's a long-winded answer. Let me summarize. One challenge is what the heck are we measuring? And the other challenge is the cultural barrier to doing any of this in the first place.
Brilliant. Absolutely brilliant. We were talking a little bit about the patients. We've drifted a little bit to the physicians, and you've quite nicely put it as physicians being autonomous rather than the autonomous experts, rather than
Right.
the accountable experts. We want to be
Indeed.
both. Yet we are seeing that the costs are rising, the administrative expenditure is spiraling out. Physicians now more so than ever are taking a back seat. Leadership has dwindled down. What would you tell these the physicians? How would you think that they should engage with versus management engaging more in and taking a primary role? Or do you think that this is not necessary anymore and data and other things, AI will help overcome this?
Wow. Okay, so let's unpack this complicated question. So, speaking personally, I've always advocated that physician leadership training is the number one thing that current leaders must do to prepare future leaders. So, starting with our College of Population Health, my sense was that we're in the business of training leaders for this complex system. Well, if that's the core business, what are the attributes that they need to know about, and then hence the issues: health economics, quality and safety, public health, and health policy. More broadly, because healthcare is America's biggest business at 20% of the GDP, $4 trillion a year, most physicians get no formal leadership training. We sort of assume that they are good teachers, good leaders, good researchers, and good clinicians all at the same time, which sadly cannot be true. As we all must admit in the mirror. So to me, leadership training is the central tenet for the future. And today, thankfully, there's lots of opportunities to get leadership training. A good example would be there are at least 15 master's degrees domestically in healthcare quality and safety, at least 15 colleges now of population health. None of this existed even a decade ago. So there are ample opportunities to achieve leadership training. However, Amir, let me just warn you, I've had the privilege of teaching literally thousands of doctors face to face about these issues. And invariably, including 2 months ago, doctors come up to me and say, you can't teach leadership. So let me just let that hang in the air for a moment, right? You can't teach leadership. Well, that's such a sad statement on multiple levels. And of course, you and I and our listeners know, well, what would you call West Point, Annapolis, Wharton, Harvard Business School? I mean, come on. So there's a rich literature, of course, on leadership and on leadership training. None of that is required in a single American medical school. None of it is mandatory. And
Brilliant.
so there's a disconnect. And then when we get out to help manage and lead America's biggest business, most physicians are woefully not prepared to do so. So if you abrogate that responsibility, well, then we get the current mess we're in.
You know, that was actually my next question. Why are we not preparing leaders when they join medical school? Similarly, why are they not prepared? It's a sort of like a similar thing. Why are they less aware of public health?
Mm-hmm.
Why are they not engaging in social media medicine
Right.
when they're in medical school? Why is that not a part?
Right.
And it's similar to when they come out of training, they should have essential core practice training to how to manage a practice.
Yeah.
So why do you think there is a big divide or a lack of understanding in medical schools
Well,
still?
I've called this, Amir, the medical barge theory of education. So here's the barge in the river, right? And the barge is weighted down with all the traditional components of medical education, right? And all the physiology and pharmacology and all the rest. And so the leaders of each of those areas claim that their content is the most important. And so here comes the barge. What are you going to throw off the barge in order to put some, quote, new material onto the barge? And I would argue sink the barge and start over and do a few things, get more persons into medical school who are not science majors, who are liberal arts majors, who from various disciplines, put in lifetime learning skills, harness ChatGPT in undergraduate medical education, and make quality and safety a top priority, because sadly, here we are in 2025 after 30 years of work, and medical error is still the fourth leading cause of death in America. So I have a radical view of medical education. It's not widely accepted, sadly. But that's why there's been a burst in the growth of population health and master's degrees in quality and safety. Traditional American medical colleges have very little interest in any aspect of this, due in no small part to lack of faculty. And also, it threatens the status quo because folks who become deans of med schools most typically are investigators who have been very successful getting their grants and have followed a traditional pathway. I'm not impugning that. I'm just declaring that we need a different model for the future. And I'm on the other side of this mountain now, Amir, so it's easy for me to say that. But I think we made a great contribution at Jefferson to create a different model. But it's not a medical school, let's be straight. It's a college of population health.
Thank you for highlighting all of those issues. I mean, I think you've summarized it brilliantly, and I think a lot of people can take a bit of guidance from this and look into the system, how we really, from the core, need to change. I think
right. Well, as you
systems
well
don't.
know, Paul Plesic taught us 35 years ago, every system is perfectly designed to achieve exactly the results it gets, right? So we shouldn't be surprised that we're in the jam we're in. I mean, it's self-evident.
Thank you. Yeah, I totally agree. You've explained it nicely. I want to go on to, before I go on to a little bit about the healthcare systems and discuss, get your views on that. Tell us, the audience, about the role of your emphasis. Why do you emphasize prevention over intervention?
Yeah,
Why do you think the healthcare system has been not able to adapt to this mindset in general, and
sure,
how is it affecting us?
sure.
What do you see as this being the downstream effects from this?
Well, you just have to look at history to understand how this all occurred, of course. So, 1965, when President Johnson signed Medicare into law, of course, they vastly underestimated what its total cost would be. I mean, by a factor of like 500x. But that was the beginning of the end of prevention because all the economic incentives plus the Hill-Burton Act to build more hospitals. So between passage of Medicare and Hill-Burton, the gloves were off. The funding flow was instantaneous to build temples of technology and have an open checkbook to write checks to do procedures. So if you combine private practice fee-for-service medicine, the Medicare Act, and the Hill-Burton, that's a toxic brew to get us exactly where we are today, which is we do more things to more people at a greater intensity than any country on the planet. And if you look around the globe, since we spend 20% of our GDP, $4 trillion, I just returned from 16 days in Australia. I gave multiple presentations and had an awesome time, but they spend 6% of their GDP. Our 4 trillion is greater than their entire GDP. And by every measure of the health of the public, they beat us by a wide margin. So is it possible to spend less and get a better clinical outcome? You bet. Reduce waste, reduce error, do it right the first time, follow practice guidelines, jigger the economic incentives so that they promote appropriate behavior. But now to answer your question, so it's no surprise in a system that's economically motivated that prevention is at the lowest level of priority because it doesn't follow the temple of technology. It's quite the opposite. Plus, if you don't get training in the issues of behavioral economics, nutrition, exercise physiology, you're not prepared to tackle the social determinants that drive the behavior that are important for prevention. And GLP-1s are a great example. Now we'll take our pill on the way to McDonald's and everything will be fine. Right. So
You're right.
if you want a quick fix, especially in America, that's part of our national mythology of who we're still in the covered wagons heading out west and, fighting the Indians and all the other dreadful issues. So that individualism drives everything. And when you add on private practice fee for service, do more, get paid more, well, that's unavoidable.
Thank you for your view. So there's a lot of work to do, and a lot of behaviors to be changed, and
Indeed.
a lot of education to be imparted. So I
You
think
bet.
that sums.
There's more stuff to do, even at pushing 70. Right.
Yeah. So, want to go discuss a little bit about healthcare systems, and there's no better place to start by discussing how you express this in your book, "COVID Crashed the System,"
Yeah.
or how COVID crashed this system. And you highlighted during this pandemic how there were lots of system institutional failures. Would like to hear your view, the key lessons that you would like to tell the audience. I'm sure there's a lot to learn from the book,
Wow.
and there's a lot of explanation and very thorough insightness into the book. But how would you summarize this as in your eyes, what were the key lessons where you think?
Well, first of all, thanks for talking about our book and my co-author Charles Wolforth and I. It was therapeutic for me to work on the book with Charles early on in the pandemic. We started writing in August of 2020, so roughly 3 or 4 months in. And then the book came out in September of 22. So basically 2 years of work. And for a small book published by a great publisher, we are past our second or third printing at this point. So it's been widely read, which I'm very, very happy about. And all the proceeds went to Jefferson, which is also very important. But to answer your question, look, I think there are a couple of take home messages. Clearly, it's all about culture. So, American exceptionalism, federalism, all contributed to the worsening of the pandemic. Let me explain. So, our exceptionalism was, hey, let's not listen to Italy or to Australia or to Israel. We're going to do it our way. Well, that was a real challenge. American federalism, let's remember governors, and at that time the Trump administration, part one especially, were fighting with one another for resources rather than having a national approach. And then, so federalism, exceptionalism, and then finally American individualism, which basically was, I care about me, I don't care about you. And again, the analogy I'll make, having just gotten back from Australia, where they have what they call mateship. You're my mate, I'm your mate, not in a conjugal sense, but as a friend. And that mateship meant that I care about you. You may not be my best pal, but I care about you, and we're going to figure out a way to help each other and make this. And so this was very, very, very important conclusion. So federalism, exceptionalism, and individualism, those are the key take-home messages. I think the other thing we learned was total lack of leadership, especially early on in the pandemic, really, really important. And then finally, a couple of positives that we could point to would be the notion of the incident command culture. So everybody here remembers that hospitals created the incident command structure, which is mandatory by law and Medicare Joint Commission during the early part of the pandemic. And within that incident command structure, that also meant that we were looking every day about how we could do a better job, right? We looked in the mirror every day to say, is it steroids? Is it prone positioning? What the hell is it? And that culture of self-evaluation, I wish we could drink from that every day moving forward, would be incredibly helpful moving forward. So that's another thing we learned. And then finally, of course, again, culture eats technology, for breakfast. So the model of when it was mostly over, we turned around and we looked at all of our other outcome measures, which were terrible, right? Back to sepsis diagnosis, central line infection, all the other things. We're just barely coming out of that right now. So let's just say, for argument's sake, we're 4 to 5 years behind. Well, the silver lining there, it gives us an opportunity to ask the question, are these the right measures? So let me summarize. Individualism, exceptionalism, and federalism, that's what America is all about. And again, I'm not impugning this. That's just what we reported to be the truth in our 2 years of work. Did other countries do better? You bet, because they had a culture that was totally focused in a different direction.
You speak very passionately, and it resonates very loudly. And
Well,
thank you for
Amir,
explaining.
what we also have to sadly recognize, just let's take a minute, right? We had 1.5 million dead. That is more deaths than every war America has fought since the American Revolution. You're talking 450,000 dead in the Civil War alone, right?
Yeah.
Nearly 500,000 dead in the Second World War. I mean, it's staggering to me. And we have forgotten, and that's because, as any good historian will tell you, when the dying stops, the forgetting begins. When the dying stops, the forgetting begins. And so help us, we are in that stage right now. Who wants to talk about COVID? Only weird guys like Nash and a few others.
Yeah. And it's worrying because you feel like, God forbid, if anything happens like that again.
Well,
Where
let's
are
not
we going to be? And have we learned anything? And if so, if these are the only things we learned, federalism, individualism, exceptionalism, and we did not take any steps after that, then we are to be blamed, to be
Yes,
honest.
well,
Afterwards, whatever comes after, we are to be blamed.
there's plenty of blame to go around in this drama, no question. And of course, there's plenty of kudos to give to lots of people, no question about that as well, including my own daughter. But more importantly, I think it's time to have a vigorous self evaluation. Are we ready for bird flu, God forbid? And the short answer, I think most of the experts would agree, we're backwards from where we were even.
And I can speak on behalf of a lot of intensive care physicians. I practice ICU medicine, and coming out of COVID, I'm
Well,
fatigued. I still feel the effects of it,
I'm sure. I get it.
and I feel like I can't do that again. I can't just go.
Yeah.
Even ICU medicine becomes very
I
painful.
think, Amir, along those same lines, if you said to the average American, you might need to put a mask back on, that's not going to happen.
Thank you for explaining that wonderful work, and I hope a lot of our viewers are going to go back and read the book, and
Thank you.
and even on an individual basis, go back and take some messages from it, try to share, educate others. That's what we got to do: educate, be prepared, and in a subtle way, be ready for the future.
Indeed.
Thank you for the contribution. Thank you for the book. Let me just go on to the next question, and that is about. I want your views on a couple of things. One is you often talk about no outcome, no income.
Right.
You have a philosophy and apply that to healthcare.
Right.
Could you explain our viewers a little bit what you mean by
Sure.
that?
Sure. We coined this phrase now, gosh, almost 15 years ago, no outcome, no income. I was searching for a pithy way to begin the conversation on what has evolved into value based care. But it's really beyond that. It imbues all the things we've been talking about: transparency, accountability, safety, reducing waste. That if you want to get paid in the system of the future, well, do it right. I mean, like every other industry. And so it's a plea in a pithy way for a very complex notion that we have to reduce waste. We got to be safer in what we do. We have to follow the science and do all the things we've been trained to do within a very complex system. And when you do all that, and the right drug and the right patient at the right time at the right dose, guess what? You get a better outcome. So the no outcome, no income is an easy way to summarize a lot of complex notions because we're in such a complicated system that's nonlinear. The only way you know if a change is working is to test it. You're not trained on how to test it. You're not trained on how to collect the data, and on and on. So to simplify all that, we came up with no outcome, no income. And boy, I think it's pretty applicable in 2025 as it was in 2008, roughly, when we began the journey to build the school and think about what would be in a curriculum for the future. So the good news is I would call it an enduring way to frame the issue.
Excellent. Thank you for explaining that. Last question, but I'm going to put it two questions in one.
Okay.
One is, want your views about the digital health and technology and AI stuff coming in, and what do you think, and how do you think this is going to influence public health strategies in general?
Wow.
And the
Wow.
second part of the question is, in your eyes, what do you think is the biggest innovation trend do you believe that is going to impact future population health? We're looking
Okay.
at sort of like a decade coming upon, and you
Yeah.
feel like, oh, Amir, if we can do this.
Yeah. Well, Amir, there's no future in predicting the future, but here goes. So, look, again, I have the privilege of being on the other side of the career mountain at this point. So, reflecting on where we're going and my work with more than 15 companies around the world where I serve as a consultant, I've learned so much in the last, especially 5 years. So clearly, it's got to be artificial intelligence and its application to medicine. A couple of sort of key milestones for me were the recognition that ChatGPT 2.0 took the board exam and got an 85% correct score. I studied for a year and got a 79 and was grateful that I passed. So wow, that was a epiphany moment for me. I think GPT 4.0 is even more powerful, and it's not going to replace us. It's going to enhance our capabilities. And our listeners know probably right now pathology, radiology have the greatest impact. It's fantastic. Prostate cancer, 250,000 biopsies. It could see, think through all of that in seconds. So I think in those arenas, we're already making some breakthroughs. And having physician leadership in those AI companies is really, really important. We don't know what we don't know. I think areas that are very exciting are risk stratification of patients. You hit the door, here are your clinical and laboratory findings. They're in the electronic record, they're scanned by the AI algorithms, there's machine learning built in, and it spits out, well, Nash is at a 45% risk of sepsis during this hospitalization. So I think the risk stratification is very powerful. And then applying what resources are we going to need to take good care of him and where is he going to end up and what's that going to cost, I think we'll be able to do all of that. So I think it's a very bright future for these tools. It's an incredible breakthrough. It appears as though it just became available in November of last year, but of course we know folks have been working on this for more than a decade at various places around the country. It just became commercially available in November of 24, roughly, but there's at least 10 years of hard work behind all this. I can't go 10 years out. I could only go 2 to 3 years out, and I really hope that we'll be able to use it as a tool to promote adherence to best practice, to do a better job risk stratification, and then ultimately also take into account things like poverty, racism, hunger, all of that, and see how that so critically influences the health of our country. So if we have measures that make more clinical sense to everybody, I think you'll get greater buy-in. So once again, I have a positive view of the future. Otherwise, I wouldn't be doing this work. And I think this is our greatest breakthrough. Amir, I hope I'm around to see some of this, That would be great. I'm confident that my daughter, Doctor, will be, and in her generation. But I think this is our biggest innovation for the future. Now, the question is, will we be able to harness it appropriately? Well, we don't know the answer to that quite yet.
Appreciate it. Excellent. I must say, Dr. Nash, thank you so much for sharing your wisdom.
Great to be together.
Yeah, it was a very, very enlightening conversation. I'm sure my viewers are going to appreciate your time, your expertise, your insight, and optimism for the future.
Thanks,
Dr. Nash. So thank you very much from the studios, from KhanKlinics. All of us were joining and giving your insight.
Great to be together. Thanks again.
To our amazing audience, if you found this conversation valuable, don't forget to like, comment, and subscribe to KhanKlinics for more enlightening discussions. We look forward to your comments at the end and your valuable insights as well. Until next time, stay empowered and blessed. Look after yourself and keep asking those questions. Good evening, everyone.